We've learned a lot from you, and we hope that you've enjoyed the day. So to wrap up today's events, we have 4 fantastic panelists who are here to discuss how open data provides opportunities for health researchers and state government to collaborate. In other words, after we all go home this evening, what are the steps that we can take to make today's conversation move forward towards improving the health of New Yorkers? So our panelists represent 4 different organizations that have been involved in this event: the New York State Health Foundation, SUNY, the Rockefeller Institute of Government, and the Center for Technology and Government. And first, I want to reintroduce Jim Nickman, who's the President and Chief Executive Officer of the New York State Health Foundation, who is sponsoring today's event. Second, I am pleased to introduce Hao Wang, who is SUNY's Chief Information Officer. Dr. Wang provides strategic and operational leadership for the governance, development, and execution of SUNY-wide information and technology strategy. He leads the SUNY-wide information technology transformation to assist and enable SUNY's core mission. Dr. Wang also leads the strategy and operation of information and technology information for the Research Foundation of SUNY, assisting the Research Foundation and SUNY strategy for the growth of basic, translational, and clinical research. Our third panelist is Teresa Pardo, who is the director of the Center for Technology and Government, who's co-organizing the event. The center is an internationally recognized leader in digital government research. Under Dr. Pardo's direction, the center works with government, civil society, and industry teams to carry out applied research and problem-solving projects focused on the intersections of policy, management, and technology in the governmental context. Governor Cuomo recently appointed Dr. Pardo to serve as his advisor to Open New York, the state's open data initiative. Sorry, handwritten remarks in there. Dr. Pardo also serves as a research associate professor at Rockefeller College and the College of Computing and Information, both at UAlbany. And finally, I want to introduce Tom Gase, who's the director of the Rockefeller Institute of Government. He has conducted research and written on American federalism, implementation and funding of social policy, the role of analysis and evaluation in state and local governments, higher education institutions and their impacts on economic development, state and local finance, the nonprofit social service sector's relationships with government, campaign finance reform, state constitutional reform processes, and the formation, financing, and strategies of political interest groups. So welcome. Let's welcome this distinguished panel. So we're hoping that this will become more of a conversation, but we wanted the panelists to each start with a couple minutes thinking about your thoughts on how open data can provide opportunities for health researchers and state government to collaborate.
Do you want me to start?
Yes, you can come in order.
You know, there's so many topics here, and there's so many types of data, but I thought I'd focus on just one, and I'll focus on healthcare data for a second. Think about all you might do with it. And there are lots of places I could start, but I'll start with one place that's probably, well, I'll give 2 examples, but there's a lot more that are real and almost there. So our foundation is working with the Department of Health and NEROV and stuff to take the Medicaid data, right? So anybody who goes Medicaid, and to basically put together these files, which already you're capable of doing, where it tells the total cost of care for an individual, say, over an annual period or over a 5-year period or whatever. But you can put together all of the data, the healthcare utilization and cost data for an individual, no matter who they see. So if they go to Albany Medical Center and then they go to St. Peter's and they go to 4 different physicians and a mental health provider, you can string all that information out into one record and get a sense of the total care that a person has received and the total cost of that care. And so that's existed, but to get that, to get that now, you have to get approved by, an information, the confidentiality, whatever, you guys know it. And And then you have to wait on the line to get the data. You'll get the data. It'll be very dirty. It'll be very hard to make sense of it. It'll take you a year and a half or 2 years. And we do that all the time. We'll fund an evaluation of something, and we wait 2 years for the data, and it's hard. So what we're talking about doing is getting this data so it's cleaned once, and there's a depository. There's somebody who has the data, maybe a university, maybe Fair Health, something like that. But it's all cleaned. It has the whole state, all the Medicaid data, and it's there. And then, and it will have identifiers. So it's what Nirav Shah called the level 3 use, where you have identifiers. But what you'll be able to do is, as a researcher, is go and say, I'm doing this demonstration on these 500 Medicaid patients who are getting cared for at this clinic, and I have these questions about outcomes, whether they're cost outcomes or utilization outcomes, whatever they are, and you'll be able to almost overnight, because there'll be a firm that can do analysis. Once you give the 500 ID numbers, for the people in your demonstration, first of all, you could have a synthetic comparison group developed using all these fancy statistical techniques to match. Or you could give them, maybe you have a control group, so you can give the 500 IDs for the people in your control group, and overnight you can get this information in a whole bunch of tables, or probably not literally overnight, but quickly. And the other nice thing about this data is it'll be up to date. It'll be just 2 months out of date. It'll get done very quickly. Well, the possibilities for this, for evaluative type of research or assessing different healthcare interventions, care management type 1 versus care management type 2, the ability to study natural variation, natural experiments is tremendous. But just as importantly, if I'm running a community health center and I'm thinking about taking capitation for my patients from Medicaid, I'll be able to find out whether the diabetics that I send to NYU end up spending more and having better or worse outcomes than if I send them to Beth Israel for their specialty care and their emergency care or their hospital care. I'll really be able to see what is the lower cost way and hopefully holding constant quality and outcomes, and you'll be able to get that. Well, that's a type of big data that I just think could transform our ability to figure out how to deliver healthcare more efficiently and effectively. So that's an example one where if that's out there, you'll have lots of opportunities. Another example is we have a grant that we're supporting the city of New York, and we have a bunch of partners. We went out and helped them raise a bunch of money from other foundations, where the city of New York amazingly does a health examination survey every 4 or 5 or 6 years, which is a very expensive survey where you actually take blood and urine and actually finding out what is the physiological health of people. And it's very, very important to understand the health of your population patterns and its trends and so on. Well, what they realized that they could do this at this point perhaps with electronic health records, because they have so many people in New York City, and the Department of Health has their own electronic health record diffusion process, and they could take these electronic health records and get the same physiological data to assess health. And what we're doing is helping to fund a matching thing that says, okay, you need to do one more expensive, and these are like $4 or $5 million actually to do these health examination surveys, and to be able to then come up with statistical methods of saying, how could I simulate what a random survey would get with electronic health data, and then you can do it live, or you can do it in real time. You can sort of update it every 3 months or every 6 months because you're getting more electronic health records every day. It just opens the door for a whole new type of research and sort of much more access to people. And so, I think those are two examples of where this big data, again, with the cooperation of government and state or city government, could really change the availability of data for people and research opportunities.
Well, first of all, I want to say what a great job that Erica and Natalie being organizing today. It's a long day, but it's a great day. So, it was, my apology, we shipped the bio randomly based on whatever it was. But why an IT guy sitting around a healthcare discussion? That's really probably some of you could think of that. I am a healthcare informatician, so all my career has been spent in healthcare industry. So As a matter of fact, I served as the board member for Spark database under both Richard Dane and Nirav Shah. So one of the vivid examples is that every quarter as a board we review quite a few, a couple of dozen research proposals from all different, Yale University, NYU. They appreciate the government's aggregation of all this critical data for 40 years. I tend to say Spark database was created in 1970s. 40 years later, it has over 150 million records for New Yorkers. And what a treasure trove. And it is clean, by the way. I just want to assure you,
That's right.
because I looked through, a lot of my colleagues from DOH today were the same people who we used to work together. It is clean, 40 years of perfection of the art of cleaning the data, link them together, protect them well, make it available to all researchers for 40 years already. You can see a lot of publication, research activity already initiated by Spark database. I think what Dr. Shah, amazingly, is that 2 years ago when I take a temporary leave from New York State, he just getting started. I was on his committee for all pair database. I know that was just preparation work. But 2 years later, you see a lot of data already online. He has an ambitious agenda. He's just gonna blow that thing even to a different scale, right? So we got to offer the data to the researcher. So let me just before I pass on to Teresa, I said I'll comment on a number of things. The catalyst function by the government is multifolded, right? One is that it acts as a data aggregator, essentially unbundled the data that was used to be confined by the agencies and by the healthcare organizations. And they've been bundling together very well. That data then, furthermore, to send to the hands of the researchers, it's a great thing, right? So that's one of the role the government played. The other one the government played was how do we fund some type of research, or how do we develop key capabilities in New York State to further that research activity. That is very instrumental. We can expand on that later. But the lastly I want to really talk about the ability to engage private industry is the key to future success. Because as at Research Foundation, I see this trend of SUNY being funded by this report, federal government, state government, private funding. That private funding has to grow because we talk about big data, talking about how do we make this thing sustainable, and undoubtedly we should engage the private industry. And we're very happy to sit next to our Health Foundation chair. But the things that a lot of the pharmaceutical companies can take advantage our data and our brain, the researchers and government populated data, to do wonderful things, to drug discovery, to do clinical research stuff. We also know that's the governor's economic development initiative, right? So if we can learn how to do that, thousands of the job that currently is outsourced to Asian countries doing clinical CRO type of work, which I know, literally, a lot of the company, they would hire 5,000 to 6,000 people who are nurses, who are doctors, who are informaticians in Asia to study the data. But I think this kind of activity that, like today, we put the researcher together with the data and put the stakeholder together with the brain, then essentially can stimulate a bigger movement, which I see will enhance New York State in a lot of ways. So let me just stop right here.
So let me add my congratulations to Natalie and Erica for such a wonderful event, and for all the folks who helped them here at RIG and other places for this event. So my background, the work at the Center for Technology and Government, is in sometimes connected to questions that matter within the healthcare context. But lots of times we ask questions that are outside of the healthcare health policy context. But what I'm going to talk a little bit about are some of the sort of the core competencies that I think are really relevant here, and then I'll ping off of those. So when the center was created, we were created with this idea of a university government industry partnership model in mind, which is essentially bring together the experts from the practitioner community who understand the complex problems facing the public sector, bring together with the academic community that has sort of the passion for the questions, the capabilities to push the questions through to new insight that will help solve those pressing public problems, but then also bring to the table the industry partners for lots of good reasons, including very technical expertise, very often very expensive technical expertise that's really critical and ever-changing within particular policy domains. So bringing those folks to the table. So that's a very important part of the way we see the world. Another part of that is a foundation of the way we do our work is research practice partnerships. And so again, bringing those communities together to help to together define the most important public problems to focus on. So we bring, again, the practitioner expertise together with the academic community and other researchers, professional or otherwise, and explore those key questions. One of the areas of our work that I think is really important here is in the area of open data. We do a lot of work worldwide in open data. And some of the questions that we get asked, regardless of whether we're in Africa, Asia, or Albany, is what are the 10 data sets, Teresa, that I should put to the web? Right? We've got the Minister of IT in Nigeria. We've got the Mayor of Schenectady saying, what are the 10 data sets we should push to the web? And I think one of the really powerful benefits of bringing researchers and practitioners together is to help get good answers to that question. What is the right data that should be made available, whether it's to the web or to behind the firewall partnerships that are necessary. So having good answers to that question, understanding, as we've talked about here, the value associated with releasing a particular data set, but also the cost associated with releasing a particular data set. I think this is one of the benefits also of these kind of research practice partnerships. We've talked a lot about the researchers as folks who do public health research, but there's also a lot of folks we could bring to this table who do information science research, who can help us understand what does it actually cost to create a solid life cycle, data life cycle model within which we could actually track provenance of the data. Who had the data? What did they do with it? When did the data get changed? So all of these things really require not just practitioners and public health researchers, but also other kinds of disciplinary specialists who can come to the table and who have great interest in the science of this process and can make great contributions to those questions. What we know from talking to people like Tanya Allard and people in the governor's program, Open New York, is it takes 3 months for them to prepare a single data set for release. It's not cheap. Right? It doesn't take 2 minutes. It takes 3 months in many cases. And so like Dr. Shah says, we have to bring lots of specialists together to fully understand the problem we're seeking to solve and the cost associated with not only using data to inform those problems once they get identified, but getting that data ready for use, and then leveraging the ideas, the models, the capabilities that are created along the way so that they can be used and reused and refined over time.
Well, I'm not sure that I have a whole lot to add, so I'll try to be brief. One of the ways in which I think that there can be a lot of collaboration is, just as Jim Nickman suggested, around the issues of evaluation. I think that there's some great opportunities for the research community to help structure trial and error evaluations using this infrastructure that is being developed. Evaluations are generally very expensive, long-term, but this gives an opportunity with this periodicity of the data, with the availability of an ongoing databases, with the and to the extent that data can be actually merged, to really provide a way of measuring what happens when small changes in administrative practices or policies are being made. I think, and that is something we know that a lot of the staff do not have a whole lot of time to analyze the data. If there are ways in which we can collaborate as researchers with the department or departments in state government or local governments, that would be a great opportunity to really do evaluations, strong evaluations that haven't been done otherwise. I think it is interesting. I think a lot the Teresa and Jim and Hal have all talked about partnerships among different institutions. I think that's one of the things that is really important here to think about. What kind of institutional arrangements, continuing institutional arrangements, and how are they going to be funded to support this kind of collaboration? It is going to require, I mean, some of the functions for these institutional collaborations are very important. We've talked about trying to merge many data sets together. That's very costly. Some of those mergers are already done within the government because of their reasons and their needs and the requirements of the federal government. But some of the mergers that are useful for researchers have not been done. So I think it's important to think about how can we set up an institutional arrangement so that these mergers of different data sets can be done in a way that doesn't weigh down the budgets of and the staff of the state and local government agencies. There's other issues too. I mean, we want this to continue. It's wonderful to have a commissioner like this who strongly supports it, but I think it also suggests that we as researchers, mostly at universities, should think about what can we do for the state that makes this obviously critical from their perspective, and not just from the point of view of a commissioner who is passionate about research, but also commissioners who might be passionate about other things. And one thing I thought one possibility I thought came up, the communities don't know how to use these data. I mean, we're going to make, this is going to mature, and the website's going to be easier and easier to use, and apps are going to be developed. But it may well be, especially in a decentralized system like SUNY, there may well be opportunities for SUNY faculty and maybe SUNY students to really explain to their communities how this website, how these data can be used in order to understand the health issues in their community, and also to sort of put it in context. I mean, these SUNY researchers might be able to, and students, if they're properly trained, might be also able to let them know about what research does suggest about factors associated with obesity or various infectious diseases or things more generally. So I think it would be a wonderful function if somehow the universities also take this up as an opportunity to help this department as well as other departments engage the community in using the data in an active way. Otherwise, I don't think it's going to happen. So that was one suggestion about sort of trying to cement this relationship between the research or university community on the one hand and government on the other. So I will stop at that.
It's gotten harder. Do we have any questions for folks here? I have one question. Interacting, you're a researcher. We've all had experiences trying to get data. Are there, and you mentioned the call that, we need to work with our government agencies to figure this out. Do you have any ideas on some models that you think would be effective? Because if we keep doing one-off researchers, it's going to overwhelm, we don't get the benefit of everybody knowing, that this data set is linked or this data set is not linked, et cetera. And so the open data portal is one way to share, to crowdsource the knowledge of that. But as working with the program owners and things of that nature, do you have any suggestions or thoughts on how that relationship between government and researchers may change?
Well, maybe Teresa, I know that Berkeley or California have worked together in important ways, but maybe you know more about, I know they had a Cal data system where they combined a lot of data for researchers in a more or less permanent or ongoing way, that you would know the
Well,
much
actually,
better than I do.
I actually don't know the answer to that one, but I think that idea might be the idea of creating such a collaborative. So one of the things that's happened in New York State government, but is happening in lots of governments around the country and to some extent around the world, is the creation of a new executive called the Chief Data Officer. So the state of New York, for those of you who may or may not know, now has a chief data officer. We have a chief security officer and a chief technology officer and a chief information officer, but for the first time, we now have a chief data officer. And that person's responsibility is varied. One of the in the state of New York, one of the responsibilities is for the Open New York portal. But also, through Executive Order 95, that person's responsibility was to lead the development of a set of guidelines that state agencies would use to make their data available. So my point is that there's an increasing presence of individuals whose responsibility it is to look exclusively at the data and the data issues, how we manage it, how we collect it, and then how we ensure that it's available for use by the communities that are interested in it. As Erica mentioned, I received a few months ago this appointment to focus on open data on behalf of the governor, and looking specifically, or working specifically with Andrew Nicklin, who was appointed as the executive director of Open New York. And his responsibility is both in the Open New York portal, but pursuing new kinds of partnerships, new kinds of organizational arrangements that would further the state's objectives in using data in all kinds of ways to support the program and policy priorities of the governor, but also of lots of other people in the state of New York. And one of the things that I think is important, I meant to mention this during my remarks, is we've talked a lot about state government, but there is a huge amount of data and interest in getting access to the data that's held in the hands of local governments. And I think if we think it's difficult to get state government data, many of you know it's that much more difficult to get data from local officials. I'll tell one last story, and then a story that Megan Cook, who works with lots of our local officials, likes to tell when we say to the mayor, do you have data that we can use for this code enforcement repository? And he says, I have data, it's under my desk, it's in my files, it's on the floor, it's in my folders. So the local government reality is quite different than the state, equally problematic.
So, here's just a random idea. Is it, first of all, it's interesting. I think most researchers don't define themselves as New York researchers, right? They're interested in national data sets or wherever they are. You're trying to answer a question or trying to understand relationships among things. But I think that it might be interesting to try and see if one could develop, you might be able to do it almost as a blog or as a, sort of a shared responsibility of whenever there's a research study that uses a New York data set, and I agree, I don't think state is the defining principle here. I mean, it could be Aetna lets you, or it could be some employer lets you use data, or Google lets you look at their health hits, or who knows what will develop out there. But anytime that data that is New York-based is used in a research study, that it somehow gets coded, written up, communicated, so that a broader set of researchers would say, oh, there's a data set I might not have thought of, you know, that maybe even, and of course, if somebody used it once, I mean, unless they're an employee of the firm or something, it means that you have a shot of convincing somebody to use it again. So that might be a shared, you know, it's almost like a Wikipedia approach where everybody contributes to developing this system.
So,
I actually I want to follow on.
well, would you like to follow
Well,
first?
I'm sorry. Well, I just wanted to say there is actually an effort going on that a few of us are part of. It's called Open 500, which is a list of the 500 for-profit companies that are actually using data that's being made available through open data channels and using that data to actually generate economic opportunity. So if you took a parallel and said, let's think about the 500 researchers or the 500 research centers or something where we said, let's create this repository of information about individuals who are using different data types and then begin to share data types,
And
data
also, you
sets.
could critique different data sets.
Exactly.
And say,
So
well,
all
they
kinds of-
used it, but
so
here's
there's-
all the problems.
So there's some emerging models like this of kind of trying to understand what we know about who's using what to do what. Sorry.
So maybe my answer to the model thing is that let me draw on two projects I did before. The first one was about 6 or 8 years ago that I led a effort in Massachusetts. We built actually one of the first functional. I'm very proud of that at that time. The Health Information Exchange pretty much is similar to our Shiny here, but then we were able to merge the data from a health plan, a inpatient, UMass Memorial Hospital system. It's a public hospital, almost SUNY's hospital system. So something like that. Then a local outpatient clinic. So that's a private-driven data integration. So I think any model that I think will work need to have a data integrator of some sort. Either it's a consortium or government, like open government is a driver for data integration. So that's one thing, right? So the other project I did was to help Blue Cross Association and AHIP to develop the national standard for personal health record, which essentially is using claim information, very much to what we're trying to do here, is let's get the claim information 10 or 15 years after HIPAA became law. Now I think the dominant digitized data in the industry actually is claim data, because at that time EMR is not prevalent. We're still watching the role of EMR, so at the hospital, the medical records are still growing. But on the other hand, we have the 10 year of accumulation of claim data. So the biggest 20 health plan in the country, including Aetna that Jim, you mentioned, we actually came to a table, all the CEOs, executives said, we got to do something with this personal health record. That was another example of private consortium come together. They represent 200 million lives in the United States. They were very happy to define. So at the end of the project delivery, we defined the personal health record industry. Eventually, some of them went on to HR. HR7 became I forgot the CDP. I confused with your organization. Essentially electronic health record for individual. That became the standard for HR7. The other part of our work went on became the standard for X12. Essentially, in hospital or paired world, 275I. That standard was extended to include pair-based personal health record. That example tells me two more ingredients of the successful model, right? One is policy, because when the largest payers come together trying to define a standard together, they focus on two things. We need standardization, because they own their data. They want this data to be portable, and we need a standard. Then the third element that I learned from that experience is policy. How do we move data around. So a lot of the project was spending on that. I think so those are three ingredients that I would offer is we need a data integrator that does not have to be government, but the government is a very powerful one. Right? Then we need policy, we need standardization, and especially to what Teresa was saying, the CDO, the key, well, I remember when we talked about this 2 or 3 years ago, whether New York State should have a CDO, both of us were proponent for that. One of the key was, in order for data to be integrated, and needs to break down a lot of policy barriers, because the policy that locks up the healthcare data was derived in the last 20 or 30 years for a different reason, right? Over this many years, you got accumulation of the policy were not coordinated. They lock the data up one way or another, and how do you break down that barrier? That's where I think the value of the government and our governor's open data advisory and our CDO will help us to do is break down those barriers. That's really ingredient number 4. But I can go on and on, but
That's good. We have one question and our last question, and then we'll say our goodbye. So here's our last question.
Oh, okay. Is this one?
Press the red mic, make sure the red button's on.
Yeah, it's on.
Hello? Okay. Well, okay, so I guess I'll end on this cynical note. I didn't realize it was going to get to that, but so we're talking about shared programs, and I guess I'll ask the classic researcher question about funding, because we have a lot of effort going into the creation of these state resources, which is fantastic, and I think just by the lists that we generated, you see a lot of investigator-initiated interest in use. What concerns me is that for the amount of effort that's going into building these and the gradual release, it sounds like it's going to be a gradually more and more massive effort, and a very public one as well. But as we were talking, researchers don't get interested in states. We're interested in generalizable information. So when you're talking about people getting funded to work with these data sets, they're going to look to federal or national level funders. And they're going to be using a state-created, state-initiated resource for non-New York purposes. Basically, the benefit, if there is any, will either be it will cynically help researchers in other states advance their careers and or not necessarily be focused on the needs of the patients who generated or entered the data. So I'm interested. Obviously, this is not necessarily the panel entirely, and I know New York State Health Foundation doesn't necessarily do research much. So I guess I'm just interested in comments and putting this on the recording. What do we do as a state to make sure that New York State researchers are actually using the data that was created by state efforts and state patients and state providers and state taxes for the benefit of the state? Because right now, it doesn't seem like there's much in terms of an investigator-initiated researcher funding profile within the state. And sorry to end on that note.
Yeah. I mean, I'll start if you want. First of all, a lot of these data, like the researchers use them as almost an extra goodie, and it's an externality, is some of these data sets, like the ones I described, are really important for providers to figure out how to be more efficient and effective, and they will have money to do that. Right? So they'll have staff, or they will contract with researchers to do that types of analysis. Now, that's not the academic research that gets you tenure, but there'll be uses of the data that's good for New York. And then I think if there are add-on uses that are good for us to better understand social science and epidemiological knowledge, I don't think anybody will complain. Our governor likes to say that New York is a leader, so if we should be a leader of creating new ideas and new knowledge and stuff. So I think as long as there's some use internally, it's not so bad if it's used outside. And I think there is, there should be money. We should be funding some research, and we do fund some. I think the state university system and private universities ought to have some funding for the marginal cost of research too, and that's a challenge that you guys should be pushing us on. Yeah.
Well, I wish you asked the question when Dr. Shah was around. I mean, I think that's a classic thing. He will answer on the state government behalf, but also you are sitting right next to a gentleman who's leading our Health Now network of excellence for SUNY system. So Research Foundation for SUNY does have funding for program on the Health Now. So I encourage you know each other and learn more from Mark.
We've submitted grants together.
Oh, wonderful. So here you go. There are some state funding available already. But I think the one more funding source that I felt very grateful to the Chancellor's support for SUNY and to the Board of Trustees of the SUNY was last weekend, the trustee approved a capital request that we drafted to support the big data research initiative. And we figured that SUNY, as a 64 campus system, we ought to have a big data capability. That capability is very real for SUNYs because we have 3 large universities, Buffalo, Stony Brook, and Downstate, all have 100 teraflop high-performance computing power. And that's a big ion that's ready, used to be optimized for scientific simulation. But we can turn around and optimize for data processing. And Dr. Shah has so much data. And, now how do we turn the data analysis from a descriptive one to a prescriptive one? It's all about how can we process data. And SUNY also has thousands, if not, tens of thousands, 30,000 faculties, by the way, who are more than capable of visualizing the data, more than capable of designing novel algorithms, not only for health, for every discipline possible. So we figure we need to construct this shared big data processing capability. And we put forward our capital request, and Chancellor was very supportive, the Board of Trustees very supportive. That's another indirect funding to this community is that as a consumer, as a researcher, you don't have to spend your time to trying to integrate data because Dr. Shah is doing that for you. He's integrating all the data. And we hope SUNY wants to do is, you don't have to spend the time or energy or your funding trying to procure computing power. Let's have that ready for you so you can access it, you can process it, and get to the bottom of it. I think that's an indirect answer to the funding question.
Great. So that's actually a great way to end this. So we want to thank our panel.